Hello and welcome back. We discussed mechanical ventilation in this episode only to the capacity that's required from general providers. That means I'm just going to select the clinically relevant points in terms of principles, modes, initial settings, specific conditions, and extubation. Definitely we cannot discuss mechanical ventilation in one or even more episodes to the level that, for example, respiratory therapists or critical care physicians master the subject. This means what is included in this episode are very high yield and directly relevant for interns or general providers, as well as advanced medical students. First, couple principles. What are the common indications for mechanical ventilation? Please review in our episode dedicated to management of respiratory failure the hierarchies of indication. Here we just briefly mention patients with respiratory failure, cardiogenic or non-cardiogenic pulmonary edema, COPD, exacerbation, or any patient who is not capable of protecting the patency of his or her airway require active intervention. Active intervention does not necessarily mean invasive intervention. What are the goals of mechanical ventilation? Reduce work of breathing. For example, think of an asthmatic patient who is becoming progressively acidotic. Think of patient comfort. This is specifically relevant for choosing the mode of mechanical ventilation at the beginning and also during the weaning process. And an important goal throughout the process to be kept in mind is prevention of barotrauma. Now, there are some variables in mechanical ventilation that we need to quickly review. We have two indices of oxygenation and two indices of ventilation, that's CO2 elimination. So what are the indices of oxygenation? They are FiO2 and PEEP, or positive end expiratory pressure. PEEP is the same as EPAP, expiratory positive airway pressure. What's the effect of FiO2? It increases alveolar and arterial pressures of oxygen. What are the effects of PEEP? Well, it prevents airway collapse by increasing surface area through the process of recruitment. Now, later on we will discuss the I to E ratio, the inspiratory to expiratory ratio. Just for now, remember, increasing that ratio, which sometimes is referred to as reversal of I to E ratio, is another means of increasing recruitment. Okay, then we have two ventilation indices for CO2 elimination, and they are respiratory rate and tidal volume. Recall that alveolar ventilation is minute ventilation minus dead space. How do we adjust these ventilation indices? We adjust them so that the work of breathing is minimized. Now remember, the work of breathing is determined by several factors, including alveolar recoil pressure as well as airway resistance. Also, if you remember from respiratory physiology, COPD is a condition associated with airway resistance, and airway resistance is a concept that depends on the flow rate. Put it simple, in COPD we do not want too much of flow, so we would usually root for larger tidal volume and fewer respiratory rates. On the other side, in conditions with decreased compliance, like alveolar collapse, pulmonary edema, ARDS, interstitial lung diseases where we are dealing with reduced compliance, the best way to minimize the work of breathing is to increase respiratory rate but lower the tidal volume. We will come to this recommendation over and over, especially when we discuss the recommended setting for different conditions. But for now, just remember this. How do we target the optimum oxygenation? We define a target PaO2 and then we play with FiO2 versus PEEP to achieve that ideal PaO2. But for now, remember, if you are asked which one of these indices decreases shunt, that is increased recruitment, that is PEEP. And that's logical, right? Shunt is when the mixing of venous and arterial blood happens without gas exchange because of alveolar collapse or impaired diffusion. So if we can increase the surface area, that's increased recruitment through PEEP, we reduce shunt. Now we have a couple very important concepts to review here in addition to the four principal variables, and they are plateau pressure and peak airway pressure, also known as peak inspiratory pressure. So I would like to draw your attention to this diagram. We begin from this point, which is at the end of a tidal volume expiration. So we are at this baseline, which is PEEP. Then we take a deep breath. This deep breath includes overcoming two opposing forces. One is airway resistance, and the other is alveolar elastic recoil. Now, please remember that airway resistance only exists when there is flow in the airways. So if at the moment of peak airway pressure, which is here also known as peak inspiratory pressure, we stop breathing and have the patient to have an inspiratory pause, there will be no resistance, and therefore the pressure drops to a value that is only associated with the alveolar recoil pressure, and that value at zero airflow is referred to as plateau pressure. So as you can see, the difference between plateau pressure and peak pressure is this airway resistance here, okay? So to put it simple, just remember that this plateau pressure here, as you can see, is the result of PEEP plus this portion, and this portion is the recoil pressure, while the peak pressure is plateau pressure plus airway resistance. So please just remember these formulas. Plateau pressure is PEEP plus recoil pressure, while peak airway pressure or peak inspiratory pressure is the total of plateau pressure plus airway resistance. Now, why is this important? Because ventilator adjustment requires us to know what setting is optimal for what type of these pressure changes. Now, if we have increased peak inspiratory pressure, there are two differential diagnoses. What are they? One is the conditions associated with high airway resistance, and that is the conditions with normal plateau pressure. And the other are the conditions associated with high plateau pressure. Again, look at this formula here. If peak inspiratory pressure is increased, it's either due to airway resistance or it's due to plateau pressure. But if plateau pressure is normal, it's necessarily due to airway resistance. So you are provided a case with increased peak airway pressure, also known as peak inspiratory pressure, and you are told that ventilator shows normal plateau pressure. What conditions you should think of? You should think of the conditions associated with increased airway resistance. What are they? We may be dealing with bronchospasm, asthma with mucus plug, and if the patient is intubated, what is a very important condition not to forget, the patient may be biting on the endotracheal tube. On the other side, if you are having a patient with increased PIP but increased plateau pressure, here it means we are dealing with a condition with increased alveolar recoil pressure. That's the lungs want to collapse. What are the differentials of these conditions? One is pneumothorax. The other is logically atelectasis and pneumonia. And finally, we are dealing with interstitial lung diseases and pulmonary edema. All of these conditions are associated with decreased compliance. That is this portion of the curve. Now, if the patient is intubated and we have a report of increased plateau pressure, what is the possible differential diagnosis? In addition to all these conditions that we mentioned, we also need to make sure that we have not intubated into right main stem bronchus. Why? Because that also causes impaired recruitment or expansion of the left lung with collapse or decreased compliance of the left lung. Now, regarding the modes, we are not required to know all the details, but we need to know what modes are in general provides less patient control and what modes provide more patient control and therefore are more suitable for weaning or improving or alert patients. Now, if you see something like this, this is the typical shape of the controlled ventilation. The patient only breathes when there is an impulse from the machine at set points, and you can see a very regular intervals and very regular amplitude for the pressures, the peak pressures that are reached, and there is no differences between the waves in terms of intervals or amplitude. So everything is controlled by the machine. This is usually the patient who is unconscious and is intubated. And this is the example of a controlled mode. On the other side, you may see a patient whose mechanical ventilation waves look like this. We have some peaks of equal amplitude at regular intervals, but in between them we have some weaker peaks, and that indicates that the patient is also breathing. So these arrows are the moments where the ventilator provides the respiration, but the ones that are in between and are usually more irregular or weaker are patient's breathing. And this means patient has some control. And this is an example of synchronous intermittent ventilation. On the other side, if you see something like this, in which all the amplitudes are equal, however, some of them, like the arrows, are initiated by the machine and some of them are initiated by the patient, this shows a pressure support in which the machine adds some pressures on top of patient's pressure to equalize the peak inspiratory flows. And so this is another example of a condition in which the patient has some control. This is pressure support ventilation. Just pay attention to my terrible drawing in the part that the peak pressures are equal. So again, returning back to our algorithm, we have two principal modes. One is the assist mode, the other is control mode. Regardless of the details, we need to know basic indications of each one. Now, in terms of ventilator setting, what are the major differences of the assist mode versus control modes? In the assist mode, we do not set the respiratory rate. Patient is capable of initiating or triggering the respirations, and the ventilator just supports it. What's the most famous examples of this? One is pressure support ventilation, as we described, and the other is assist control modes, which could be volume control or pressure control. So you would see AC/VC or PC. What about the control modes? Well, there are several types of control modes. The main difference is that ventilator sets the respiratory rate. Now, what is the most common type of controlled mode? That is SIMV, or synchronized intermittent mechanical ventilation. Major question: if your patient is not alert, which one of the modes should be used? A controlled mode should be used. Next important question: if the patient is improving, or if we are planning weaning, what modes should be used? We use assisted modes. On the other side, if the patient is deteriorating, what modes are preferred? Controlled modes. Which mode provides a guaranteed ventilation by machine while at the same time allows the patient to have his own respiratory rate and tidal volume independent of machine? That is SIMV. Remember, there are other controlled modes such as PRVC and HFOV, or jet ventilation. PRVC stands for pressure regulated volume control. And if you are asked which one of these modes control all factors and patient almost has no contribution, that is PRVC. Tidal volume, respiratory rate, FiO2 and PEEP are all set by the machine. Now, quick review of the medications used during the processes of intubation and for mechanical ventilation. Remember, for intubation, we use induction agents as well as muscle paralysis agents. The most commonly used induction agent for intubation in ER is what? It's etomidate. We mentioned in the management of respiratory failure episode that we use neuromuscular junction blockers such as rocuronium or succinylcholine for paralysis. What type of medications are considered for mechanical ventilation? The patients need to be kept sedated. The drug of choice in the ICU for mechanical ventilated patients is propofol. Couple high yield points about propofol. True or false, the patients under propofol sedation does not need analgesia. That's false. Propofol is not analgesic. What medications should be avoided if we use propofol for sedation? Paralytic agents should be avoided. What's the effect of propofol on ICP? It reduces ICP and risk of brain edema. Now, a very high yield subject is initial settings for mechanical ventilation. If you do not have time to memorize this brief summary or details, just remember three things. We initiate with high FiO2 and then gradually decrease it in parallel with adjusting PEEP. It means we initiate with low PEEP and then we gradually increase PEEP. Why this is a strategy in hypoxic failure? Because this helps prevent oxygen toxicity. Remember, the patients should not receive high FiO2 for a long period of time. So we mainly depend on PEEP or recruitment for the oxygenation. The second principle is keep the tidal volume at the value of 6 to 8 milliliter per kg, except in the cases of ARDS and interstitial lung disease and fibrosis, or generally decreased compliance conditions, as we discussed, where reducing work of breathing requires low tidal volume ventilation, and in those conditions we keep the tidal volume of 4 to 6 milliliter per kg. If you just remember this, you will be safe. But if you want to know a little bit more for the initial setting, remember this: the recommended initial mode is SIMV, as it benefits from both ventilator and patient's contribution. Also, it provides comfort for the patient. Except for the conditions associated with decreased compliance and high alveolar recoil, initial respiratory rate is set to 10 to 12 per minute. PEEP, or continuous positive airway pressure, is usually kept at 5 to 10 millimeter mercury. Pressure support on top of the PEEP is itself, again, most commonly 5 millimeter mercury. Remember that plateau pressure, we tend to keep the plateau pressure less than 35. Plateau pressure is measured in terms of centimeter water. And then we have a very important set of initial adjustments to make. Remember, increasing PEEP would reduce CO2 elimination. So if the patient has hypercapnia, we never want to increase PEEP. We want to completely squeeze our alveoli to get rid of the CO2. We don't want to keep them open at the end of expiration. Again, that's why we keep saying that high PEEP is the ideal intervention for hypoxic respiratory failure. Not high FiO2, because that cannot be a long-term strategy, but high PEEP. What are the other reasons we want to avoid high PEEP in hypercapnic failure? Always remember, increased positive end expiratory pressure also causes collapsed pulmonary capillaries. Collapsed pulmonary capillaries means increased dead space, and that is a basis of actually hypercapnic failure, if you again return to our formula of minute ventilation. Now, next case just focuses on our understanding of hypoxic versus hypercapnic failure. If you have patient with respiratory distress and SaO2 is more than 90%, what factors we need to focus on? We need to focus on factors of ventilation, and the first thing to adjust is respiratory rate. What is the target? Target PaCO2 is usually less than 45 millimeter mercury. Now, what factors determines required adjustments for tidal volume? Underlying condition combined with patient weight are the most important initial factors. And by that, I simply mean low tidal volume for low compliance conditions such as ARDS, and that's when we go for 4 to 6 milliliter per kilogram. Otherwise, we stay with 8 milliliter per kg. Now, the secondary adjustments are determined by acid-base status of the patient when we try to adjust the tidal volume. We have a couple of very important cases right now that we are going to discuss in a minute. Next is a case of a patient on mechanical ventilation, and you are required to reduce the possibility of barotrauma. What are the most important indices to look for? We want to make sure that peak airway pressure, or PIP, is less than 40 centimeter water, and plateau pressure is less than 30 to 35 centimeter water. If you are asked what is the most important index associated with barotrauma, that is PIP, peak airway pressure or peak inspiratory pressure. What's the secondary index to adjust to avoid barotrauma? Tidal volume, and we again aim at a tidal volume of 6 to 8 milliliter per kg, not more. What is the most common treatable side effect of mechanical ventilation and how to address that? The most common side effect or complaint is patient's anxiety. The way to address that is to use patient-driven modes. Pay attention to the fact that I didn't say use assisted modes or controlled modes, because some of these patient-driven modes are assisted modes and some of them are controlled modes. So what are these patient-driven modes? We need to know this. They include pressure support ventilation and SIMV, synchronized intermittent. Also add to this CPAP. These three modes provide the highest level of comfort for the patient. Now, regarding preventive measures, how can we avoid intubation-induced bronchospasm? We either use lidocaine or aerosolized beta-2 agonists prior to intubation. Important question, true or false, in order to prevent infectious complications, frequent changes of tubings of mechanical ventilation is recommended. That's false. Frequent changing of tubing is not preventive but permissive for infection. An important question regarding hemodynamic status and adjustments for PEEP. What two groups of patients should not have high PEEP? One is the one that we already discussed, and those are patients with CO2 retention, because as we mentioned, PEEP, if it goes high, would collapse the alveolar capillaries and increase dead space, and also would impair ventilation. The second group of patients are those with low blood pressure or shock. Why is it so? Because it reduces venous return and further worsens the cardiac output. Remember, PEEP is like Valsalva. It reduces the preload. True or false? We should avoid high PEEP in patients with congestive heart failure. That's false. In especially acute exacerbation of heart failure, the ADHF, we want to reduce the preload, as the increased preload is the basis of congestion, and thus patients with congestive heart failure benefit from PEEP. Now, initially in this episode I mentioned a second means to increase recruitment and surface area in addition to PEEP is reversing the I to E ratio. Now remember, in normal condition the inspiratory to expiratory phase has a ratio of 1 to 2. This could increase to 1 to 1 during exertion. In COPD, what's the ratio? COPD is a condition with prolonged expiration, so I to E ratio is 1/3. By reversal of I to E ratio, we mean a ratio greater than 1, and this can increase alveolar recruitment. What are the possible shortcomings or side effects of such an approach? For example, you have a mechanical ventilator setting with an I to E ratio of 2, and you are asked if this is a good strategy for a COPD exacerbation. The answer is absolutely not ideal for COPD, because in COPD we need CO2 elimination, therefore we need prolonged expiratory phase. The other side effect associated with inversed I to E ratio is auto-PEEPing or breath stacking with increased risk of barotrauma. However, if the patient does not have hypercapnic respiratory failure or COPD, we may consider a trial of reversal for I to E ratio. However, always remember, such an intervention requires patient to be sedated. What are the recommended initial setting for respiratory failure? We do not change much of the initial setting. We may consider FiO2 of 100% at the beginning. We prefer AC mode and a respiratory rate of 14. You do not need to commit to memory these numbers, but knowing what is the emphasis in hypoxic versus hypercapnic failure. So what are the recommended settings for hypoxic failure? Hypoxic failure, working with indices of oxygenation, that's FiO2 and PEEP. Again, as we mentioned, the initial setting is we begin with high FiO2, that's usually more than 60%, and a low PEEP, that's usually 5 centimeter water, and then we gradually drop FiO2 to values less than 60 to 40% while increasing PEEP. We keep an eye on our goal of oxygenation, which is an SpO2 of 92 to 94%. Remember, there is no point of aiming at higher SpO2. Is there any exception where we need higher SpO2? Yes, hyperbaric oxygen is the treatment for carbon monoxide poisoning. What other considerations are important in hypoxic failure? Remember, we need to have some form of lung protecting strategy. and considerations for patient's comfort. And so we go for moderate to low tidal volume around 6 milliliter per kg. But again, we need to identify the type. If the failure is due to ARDS, we will go for even lower tidal volume, which is 4 to 6. Consideration for patient comfort are what we initiate with some of our patient-controlled modes such as SIMV or ACPS, assist control, pressure support, and keep the initial settings for comfort such as respiratory rate around 12 per minute. Is it possible that we initiate with non-invasive ventilation connected to our mechanical ventilation for acute respiratory failure? It is possible. Some references say always initiate with intubation in the acute setting, but some other resources say we can give a trial of BiPAP and see if we get any results. However, the rule is if for 60 to 90 minutes non-invasive ventilation fails to address patient's oxygenation, we need to intubate patient. When we increase the PEEP, what side effects we should look for? Hypercapnia, hypotension, barotrauma, and other manifestations of Auto-PEEP. We'll discuss it under COPD setting. Now, before discussing the recommended settings for hypercapnic failure, I would like to discuss a subtype of hypoxic failure that's very high yield for mechanical ventilation setting, and that's ARDS. If anything, just remember it is a low tidal volume ventilation. Because of low tidal volume, in order to avoid hypercapnia, we need to raise the respiratory rate for our target PaCO2, which is what? It's around 40 millimeter mercury. Once more, how do we adjust the oxygenation indices? We initiate with high FiO2, then we gradually drop it while increasing PEEP. What's the target FiO2? Target FiO2 is less than 60%. It's usually between 40 to 60%. What's the target PaO2 in general for the ventilator setting? PaO2 of 60 to 90 millimeter mercury. Okay, now let's discuss the recommended settings for hypercapnic failure. We see the patient based on clinical presentation and ABG, or based on capnography, to have a PaCO2 greater than 45 millimeter mercury, which could be mixed with hypoxic failure. So again, as you know, we need to adjust our ventilation variables, that's respiratory rate or tidal volume. Depending on mode of the respirator that we use, we adjust them to reach the target PaCO2 of less than 45 to 40 millimeter mercury. Again, the type plays an important role in the adjustments needed. For example, if hypercapnic failure happens in the setting of acute exacerbation of COPD, we initiate with a BiPAP trial. That's always the recommended first approach. The second condition we need to be on alert in management of hypercapnic failure is to avoid high PEEP. Especially in patients with COPD, we need to be on alert on Auto-PEEP. Very important question. What is the target PaCO2 in hypercapnic failure? The target PaCO2 is the patient's baseline. What does this concept mean, especially in the COPD cases? That means permissive hypercapnia. Okay, so let's discuss the ventilator setting in asthma and COPD. Now, as you can see, even though we mentioned that the goal in hypercapnia is to increase indices of ventilation such as tidal volume or respiratory rate, here in the case of COPD, we have to be specifically cautious about the risks of barotrauma associated with increased tidal volume or the risks of increased dead space associated with increased respiratory rate. And so therefore, we focus mainly on a separate index, and that is the I to E ratio. You remember we mentioned the inspiratory time to expiratory time ratio is usually 1 to 2. In acute exacerbation of COPD, we want to provide a means of ventilation to the patient that not only provides enough oxygenation, but also enough time to exhale. Two important factors in the course of management of COPD with mechanical ventilation is one, the SpO2 and PaCO2 goals. Again, remember, we don't want SpO2 more than 88 to 90%, so that some mild hypoxia can function as the trigger for respiratory drive. Also, we do not want to treat patients' numbers in terms of PaCO2, and the goal of PaCO2 is patient's baseline. Otherwise, the moment the patient is disconnected from mechanical ventilator, he may demonstrate acidosis. The second point is a big concern in the management of COPD with ventilator, and that is the high risk of auto-PEEPing. The patients already have some degree of air trapping. They already have some issues with high resistance during the expiration, and therefore risk having auto-PEEPing. Remember, what are the possible clinical manifestations of auto-PEEPing? Impaired venous return that translates into dropped blood pressure and reduced cardiac output, plus worsening of dead space, air trapping, and CO2 retention. Case: you have a patient with history of COPD who has come to emergency room with altered mental status, and the ABG shows evidence in favor of mixed respiratory failure. You initiate BiPAP non-invasive ventilation, but patient does not respond during your 90 minutes monitoring, so you perform elective intubation. Capnography and x-rays demonstrate proper placement of endotracheal tube, and the patient condition gradually improves as evident by follow-up ABG. At around 11 p.m. you receive a phone call from ICU informing you that the patient's blood pressures reading are dropping. Question number 1. What are the possible differential diagnoses? One possible diagnosis is pneumothorax secondary to barotrauma. That's possible in any patient undergoing intubation, but especially in patients without lung protective indices, or the patients who have high risk of auto-PEEPing, like COPD exacerbation patients. Second possibility is just auto-PEEPing without pneumothorax. Remember, increased end expiratory pressure means decreased venous return because of collapsed alveolar capillaries. Third question: what strategies could have helped avoid this condition? Three major strategies in ventilator setting. One is in patients with COPD, we keep PEEP less than 5 centimeter water. Remember, in all other conditions we mentioned, when we are dealing with hypoxemia, we initiate with high FiO2 and low PEEP and gradually increase PEEP and reduce FiO2. In COPD, especially if the patient's hypoxemia is addressed, we do not want to increase PEEP because the patient has high risk of barotrauma. Second strategy is referred to as square waveforms, in which a fixed flow is provided during inhalation. But most important strategy are strategies associated with reducing I to E ratio. As you remember, I mentioned I to E ratio in normal individuals is 1/2, and in COPD is 1/3. However, if we reduce it even further, we can provide enough exhalation or expiration time to patient to avoid air trapping and auto-PEEPing. So next question is, what are the strategies to reduce I to E ratio? Well, one is to lower the respiratory rate, given the fact that the larger portion of respiratory cycle is dedicated to expiration at normal conditions. In lower respiratory rates, we will have prolongation of expiratory time and therefore further reduction of I to E ratio. The second strategy is to facilitate expiration, and that is by providing bronchodilators to reduce airway resistance. Most importantly, there is a strategy referred to as decelerating flow pattern that, similar to square waveforms of inhalation, is a strategy to increase inspiratory flow. Remember, if we increase the inspiratory flow, we can reduce the inspiratory time, and therefore a longer portion of the respiratory cycle could be dedicated for expiration, avoiding auto-PEEPing. Now, what is this deceleration flow pattern? It's just highest inspiratory flow is delivered at the very beginning of inspiration, and then we gradually reduce the flow. This helps avoiding very high peak inspiratory pressure while at the same time reducing inspiratory time. Now, if these adjustments don't work, what are the next steps in the management of auto-PEEPing patient? If our most important strategies, that are the three strategies for reduction of I to E ratio, don't work, we need to assure adequate sedation, as patient may be fighting the ventilator, be anxious, or the patient may be hyperventilating. You remember in one of our SIMV modes, both patient and ventilator contribute to patients' respiratory cycles. However, if none of these strategies work, we need to disconnect the patient from ventilator and allow the air to be completely exhaled. And this is specifically important if the patient's hemodynamic status is compromised by hypotension or shock. The final scenario is a patient with ICP elevation connected to ventilator. What are the recommended settings? Remember, in patients with increased intracranial pressure, we need to avoid hypercapnia because of cerebral vasodilation secondary to hypercapnia can worsen ICP elevation. Therefore, here is the real scenario in which our focus is to really reduce PaCO2 to values less than 40, and this is the only condition in which our target PaCO2 in the mechanical ventilation is less than our standard target. How do we do that? We make sure that tidal volume is 6 to 8, but can be as high as 8 to 12 milliliter per kg. Also, respiratory rate could be as high as 10 to 18. And the goal here for PaCO2 is to be less than 40. Remember what was the highest respiratory rate possible? In ARDS, respiratory rate could be as high as 30 because tidal volume could be as low as 4 to 6. Here we combine both factors to some extent. Should we worry about oxygenation in ICP elevation? Yes, we need to also optimize PaO2 to be less than 70 millimeter of mercury. So again, we play with our FiO2 and PEEP values. Now, if you are asked what is the preferred mode in a patient with head trauma connected to ventilator, remember PSV mode, pressure support mode, is the one that benefits highest CO2 removal and therefore helps lowering ICP. Final important scenarios to discuss briefly are the ABG abnormalities during the course of mechanical ventilation. What's the overall frame for monitoring ABG during mechanical ventilation? We first tend to manipulate tidal volume. Again, as you remember, patient's weight is the most important determinant, but also the underlying condition. We mentioned that we can go as high as 12 milliliter per kg in ICP patients, or we have to remain in the very low tidal volume of 4 to 6 milliliter per kg in ARDS and interstitial lung disease patients. Now, if the tidal volume is within the recommended range for the disease and for the patient weight and condition, and still the patient has some ABG abnormalities, then we manipulate respiratory rate. Respiratory rate is determined not only based on patient condition, but also based on ventilator setting. We discussed some examples based on patient's condition, such as high respiratory rate in ICP and very high respiratory rate in ARDS and interstitial lung disease. Next is a case that patient on mechanical ventilation has PaO2 greater than 80. True or false? The patient is within the target range and we don't need any adjustments. That's false. Except in the cases of carbon monoxide poisoning, we do not want FiO2 to remain high or PaO2 be higher than 70 to 75 or 80 maximum, or SpO2 be more than 90 to 94%, because this means risk of oxygen toxicity. So the required management in this situation is to reduce FiO2 to values less than 60 or even less than 40% if needed, at least temporarily. Patient that's connected on mechanical ventilation needs some adjustments. How do we know if we need to manipulate any of the ventilation indices such as tidal volume or respiratory rate? That's again based on PaCO2. If PaCO2 is within normal range or target and that is less than 40 to 45, depending on the condition, we don't need to change the ventilation setting. Again, it depends on the condition. In patients with COPD exacerbation, the baseline COPD is the target. It could be even as high as 50. In patients with almost all other conditions, the target PaCO2 is less than 45. In patients with ICP elevation, the target PaCO2 is less than 40. Except for the ICP patients, the patients connected to mechanical ventilator is reported to have PaCO2 less than 36. What is your next intervention? We need to reduce tidal volume first, but if tidal volume is okay, we need to reduce respiratory rate, whatever shows to be higher than our standard setting. You remember, The initial or recommended setting for tidal volume is usually 6 to 8 milliliter per kg, and for respiratory rate is around 10 to 12 per minute. By the way, do remember what is the recommended plateau pressure and peak inspiratory flow. The recommended inspiratory flow rate goal is usually 60, that's 60 liters per minute. Maximum recommended peak inspiratory pressure is 35 to 40. We usually want it to be less than 35. And for the plateau pressure, we want it to be less than 30 centimeter water is the unit. Okay, the final high yield subject is extubation. Briefly summarize the steps involved in extubation. First step is spontaneous breathing trials, and patient readiness criteria are evaluated on a daily basis. If the patient passes the trial successfully and demonstrates readiness, we pick a mode for the patient's weaning from ventilator that provides ease of patient's interaction with the ventilator when the patient is alert. Examples are PSV or CPAP. And if the patient successfully interacts and, for example, does not desaturate, we extubate patient and monitor him closely for a while. This is what extubation is about. Define SBT. During a spontaneous breathing trial, the patient is still connected to ventilator, but the ventilator support is turned off and patient is allowed to breathe on his own. The time is usually for 1 to 2 hours. This is usually accompanied by what's referred to as sedation holiday. That's we either don't sedate the patient during the trials or we just provide half regular dose for sedatives. What are the required criteria? For spontaneous breathing trial readiness, simply put, patient should have minimum requirements for the indices we discussed. So patient should require less than 40% FiO2, patient should require less than 5 centimeter water PEEP, patient SpO2 should be more than 90% at least, and P to F ratio should be at least 150. Patient pH should be more than 7.25, and clinically the patient should be stable with ability to initiate the respiratory efforts, and the cause should have been improved. Briefly describe the process of weaning. If the patient demonstrates readiness criteria and successfully passes spontaneous breathing trial, we put the patient on one of the easy to interact modes such as SIMV or PS. Again, alternative modes are CPAP or TPs. Then we gradually reduce the indices provided by ventilator. For example, we reduce FiO2 gradually to values less than 40%. We reduce PEEP to value less than 5 centimeter water. And finally, we reduce the pressure support on top of the PEEP. Plus, we keep monitoring SpO2 and patient's ventilation indices. Now, among all the required criteria, what are the most important 2 criteria to demonstrate readiness for spontaneous breathing trial? One is the pH greater than 7.25 and the other is SaO2 of at least 90% on FiO2 of less than 40. Final question of this episode: if the patient on ventilator persistently fails SBT for 7 days minimum, what is the next step? This means the patient needs long-term airway, and that is achieved by surgical airway through tracheostomy. Okay, I try to include all the important clinical high-yield points and facts about mechanical ventilation. A lot of subjects, of course, are not included, but this should provide us with the clinical understanding of these variables. Thank you.